Thank you, sir. It's an opportunity. It's indeed a honor and pleasure to be part of this scientific feast. So I am straightforward going for my video here. So
Deep keratitis. Why so scary? Because it is a big diagnostic and therapeutic challenge due to its location. It often doesn't respond to topical as well as targeted therapy like intrastomal and intracameral antibiotics. A 66-year-old male presented with peripheral deep corneal stromal abscess with visual acuity of finger counting at 2 feet. He did not respond to topical as well as targeted antibiotics. So we used a novel approach, posterior lamellar keratectomy, where we excised infected posterior lamella without transplanting any graft. A peritomy was done next to the stromal abscess. Then a partial thickness scleral incision was made and tunnel dissection was done anteriorly and 0.5 mm beyond the stromal abscess. Anterior chamber was then entered using a keratome just posterior to stromal abscess. Viscoelastic was injected and the dissected posterior corneal lamella containing the stromal abscess was grasped with toothed forceps and excised using curved Vanna scissors. Anterior chamber was thoroughly washed and 360-degree posterior synechialysis was done. The scleral tunnel was sutured with continuous tenonylon sutures and the wound was hydrostitched. On postoperative day 1, there was gross corneal edema and dense fibrinous reaction in anterior chamber. The posterior stromal defect could be seen hazily. At 2 weeks follow-up, anterior chamber was quiet with completely clear cornea. The uncorrected visual acuity was 6/18 part with no ectasia and no bullous keratopathy at the site of posterior stromal defect. In conclusion, posterior lamellar keratectomy is a simple and effective technique for managing small peripheral deep-seated recalcitrant keratitis. It leads to radical cure like therapeutic keratoplasty in a less invasive way and without the donor graft need. Thank